We have here a model of the aortic and mitral valve annuli. This is a 23 millimeter St. Jude mechanical aortic valve, and I have attached it to a 26 millimeter Carpentier-Edwards Physio 2 ring. It's been attached by a couple of sutures, which would correspond to in the natural valve to the lateral and medial commissures of the mitral valve. So the lateral commissure of the mitral valve is locked onto the nadir, to a region that's very close to the nadir of the left coronary aortic valve leaflet, and the medial commissure of the mitral valve is attached to the nadir of the non-coronary aortic valve leaflet. In life, there is a slight gap between the line of insertion of the aortic valve leaflets and the anterior mitral valve leaflet commissure, but there is a definition now of the aortic annulus, which is no longer the crown-shaped insertion line of the aortic valve leaflets, but is a planar ring called the virtual basal ring. And it corresponds to a circular line that connects the nadirs of the three aortic valve leaflets together. So in the natural valve, there is a gap between the anterior mitral leaflet and the line of insertion of the aortic valve leaflets, and this is called the aorto-mitral continuity, or sometimes called the interleaflet triangle between the non-coronary and left coronary aortic valve leaflets. If we look at the model from the side, if you look at the model from the side, we can see there's this angle between the plane of the aortic valve at the virtual basal ring and the plane of the mitral valve annulus. Now, the part of the mitral valve annulus that's attached to the aortic valve complex does not move, it's fixed. But the part of the mitral valve annulus that has an insertion into the muscle of the left ventricle does move, and it can move either away from the ventricle or towards the ventricle. And this gives rise to variability in what we call the aorto-mitral angle between the planes of the two valve annuli. So in functional mitral regurgitation, there are two types. There's a type of functional mitral regurgitation where the annulus is pushed away from the left ventricle. We call that atrial functional mitral regurgitation. And there's also a type of functional MR which is brought about by the annulus being dragged down into the ventricle. That's called ventricular functional mitral regurgitation. Because the left ventricle is cone-shaped, then this has surgical implications, because if the mitral annulus is pushed away from the ventricle, the mitral annulus will dilate and be of a greater diameter than if it's dragged down into the ventricle, in which case the mitral valve annulus will become smaller in diameter. And this is very relevant to mitral valve repair, where annuloplasty is carried out routinely, because if the valve annulus is enlarged to start with, then there's no problem in reducing the diameter of the valve annulus. But if it's already at a narrow starting point, well, you run a high risk of causing mitral stenosis by carrying out an annuloplasty. It's also relevant to surgical planning, because where the aorto-mitral angle is obtuse, then the surgeon has very good visualization of the mitral valve, whereas when it's an acute angle, the visualization is not nearly so good. And so it's much easier to repair valves that have an obtuse aorto-mitral angle. Furthermore, where the angle is acute, there's going to be a risk of systolic anterior motion, because following a mitral valve repair, the anterior leaflet will be pushed more towards the left ventricular outflow tract, particularly if there's been an aggressive annuloplasty. Whereas with the obtuse angle, this is not nearly so much of a risk, and you can be a bit more aggressive in terms of undersizing the mitral annuloplasty ring. This is a whole mount preparation of the anterior mitral valve leaflet. It has been stained with Van Giesen stain and mounted in silicone in a petri dish. we can see the papillary muscles with their attached chordae. The shorter chordae are always arising from the lateral papillary muscle, and the longer ones from the medial papillary muscle. So we therefore can orientate ourselves. Here is the line of insertion of the aortic valve leaflets, and this is the left coronary aortic valve leaflet insertion line. This would be the position of the left coronary ostium. This is the lateral commissure of the mitral valve. This is the medial commissure. This faint brown line corresponds to the line of insertion of the roof of the left atrium into the back of this junction point between the left ventricular outflow tract and the anterior mitral valve leaflet. So anything below this line is called the anterior mitral valve leaflet. Anything above it is called the aorto-mitral continuity, or it can also be known as the interleaflet triangle between the left coronary aortic valve leaflet and the non-coronary aortic valve leaflet. The older literature describes the line of insertion of the aortic valve leaflets as being the aortic valve annulus, and surgeons often still think of it that way, but the definition of the aortic valve annulus has changed in recent decades to correspond to a theoretical or virtual ring which connects the nadirs of all of the aortic valve leaflets, and it's called the virtual basal ring. So the virtual basal ring, when it became popular, suddenly it was realized that there were these triangular structures above the virtual basal ring between the leaflets of the aortic valve, and Robert Anderson was one of the first to point this out in his paper entitled The Forgotten Interleaflet Triangles. It could equally well have been called the newly thought of interleaflet triangles, and then these terms can be considered interchangeable for this portion of the cardiac anatomy. It can be called the interleaflet triangle, or it can be called the aorto-mitral continuity, and it has a distance of 5 to 10 millimeters in extent. It's worth noting, while we're considering the aorto-mitral continuity, that this line of insertion of the wall of the roof of the left atrium demarcates a point whereby if we were to make a hole in the anterior mitral leaflet here, it would take us into the left atrium. But if we were to make a hole in the aorto-mitral continuity here, it would take us into the transverse sinus of the pericardium. And all experienced cardiac surgeons have had an aortic valve replacement case which had terrific bleeding after coming off bypass from the transverse sinus. And when that happens, this is the area you have to think about, because it's probably due to overzealous decalcification in this area, or it may be due to friability of the aortic valve tissues, and there's been a perforation into the transverse sinus from the line of insertion of the aortic valve leaflets. And this is a situation which traditionally some surgeons have considered to be hopeless and have abandoned the patient. But it can be corrected by going back on bypass, transecting the ascending aorta, bringing the aorta forwards and exploring this area of the aorto-mitral continuity from behind the aorta, behind the ascending aorta, and finding the hole and suturing it with a pledgeted stitch. So I hope this short overview of the anatomy of the aorto-mitral angle has been helpful. Once again, it cannot be stressed strongly enough that understanding the anatomy of the heart thoroughly is key to operating safely upon it.